I guess that's the point of the whole question too. Are you finding ways to get the drugs available to these people, or is it just they're just pretty much out there in the limbo?
There are several programs in place. In the United States, we have what they call PEPFAR, which is the Presidential Emergency Plan for AIDS Relief. The $15, which was initiated by President Bush, with an amount of $15 billion over 5 years. We are telling activists to get involved so that we can increase the amount. Other countries, the rich world, they can do the same. Okay, they can increase the amount, they can donate to this cause, so that by doing that, we can make drugs available to everyone. If we, let's say for example, if we decide to tax people in the rich world $20 a year, and there are about 1 billion people working in the rich world, so that's $20 billion. Mm-hmm. So with $20 billion annually, we can solve most of the AIDS problems in the world. So the issue here is about telling the rich world to get involved, just like the United States is getting involved. And then once they get involved and serious about it, we're able to solve most of the problems of AIDS all over the world.
You've been pretty much going back and forth to Nigeria to maybe in a way work with your colleagues over there. I want to ask you, how has the experience been over there?
They welcome me. There's a need for us to do that. Those of us who are here in the United States, or I should say overseas. There are over 12 million, about 12 million Nigerians overseas, outside Nigeria.
That's a lot of numbers right there.
It's a huge number. Even here in the United States, about 3 million Nigerians. We have to find a way to link up with the respective sectors of society, the professional groups. I've done mine through science and through the medical areas, linking up because it's easier for me to do that initially and then expand. They welcome the idea, they're willing to work. The infrastructure may not be there the way it is with what you expect, but if you don't work with them and try to build capacity, then there is no way you could build infrastructure. And I think that's why I'm a very big believer of linkage. Linkage with experts in the diaspora. The Nigerians back home need to do something about it. The government, the universities, various sectors of society, they need to do something about it. And then the folks who are here also in the United States also need to find a way to extend their hand. So that way we can all collaborate and then eventually help society, because that is the bottom line.
Are you getting any positive feedback as far as a linkage idea?
Well, I just, like you just mentioned during the introductory speech, a session here, that, I led the team that was put together by United Nations to look at capacity assessment for the for Global Fund Round 5 in the area of HIV/AIDS, tuberculosis, and malaria. The rest of the consultants were Nigerians, based in Nigeria. So I came from here to lead the team. So that tells you clear cut that folks back home are willing to work with the people outside. If you provide an enabling environment, for them to do the work. So we have to find ways, to create an enabling environment so that the professionals in the United States can link up with the professionals back home. And that's why, that's why I think it's very important, for the current Nigerian government to engage Nigerian professionals outside. Because if they don't make that move, it's going to be difficult for them to fish out these Nigerian professionals outside. So I still think that the professionals outside shouldn't wait for them. They should start making the moves themselves. It could be from your local government, and then to your state, and then to the federal level. At least make the initial steps, because they may not know that they're supposed to be doing ABC. So when I talk to folks in Nigeria, I constantly remind them of the importance of this linkage, because you have so many people outside that you can tap from who are willing to work with the folks back home.
Yeah, people are willing to work, but you mentioned severally about the lack of enabling environment and the infrastructure. And when you don't have that, even though your spirit is very high, you want to do the right thing, you want to work, you know, if you don't have that, you really can't do much. And that, to me, is one of the critical challenges of that continent, the provision of adequate infrastructure. How are you guys in the medical community in Nigeria coping with that lack of infrastructure in terms of efficiency and effectiveness of your work in this area?
Those are the difficult things facing sub-Saharan Africa. It's a big drawback because there's not much you could really do if the infrastructure is not in place. But you can't let that stop you. You still have to devise a way to tackle it. You know, the treatment of HIV/AIDS, for example, is individualistic in the rich world.
Okay. I don't understand what do you mean by that.
Every case is different.
Okay. How is every case different if everybody's having the same disease?
Where two individuals who are HIV infected doesn't necessarily mean that they're going to be treated the same way.
Okay.
Because these drugs are cleared through different organs of the body. Some are excreted on change through the kidney, some through the liver. So then you have to basically look at individuals very, very, very differently. Okay. Some of the HIV-infected individuals have comorbid conditions in terms of disease states. So which means that if they have tuberculosis, for example, you have to make sure you choose those drugs that are not going to interact, you know, with the drugs used in treating tuberculosis, different things of that sort. So that's what I mean by individualistic.
Okay.
But in the case of sub-Saharan Africa, even though we know for sure that these cases are individualistic, you could still find a way to design a public health approach, okay, which is what we've told them over there, where you may not have all the tools available to handle the cases just like what is the way it's supposed to handle the cases in the rich world. But that doesn't mean you're just going to ignore it because you don't have all the tools, okay? You design various formulas to make sure you still tackle the cases. That's what I mentioned about the public health approach. So, but if you sit back and just says, well, things are this way in sub-Saharan Africa, that you're not going to approach it, then nothing gets changed.